colorectal cancer represents a major cause of morbidity and mortality in Western countries. CRC screening has been shown to be effective in reducing CRC incidence and/or mortality, and population-based screening is widely recommended in Europe. The effect of endoscopic screening is conveyed by two mechanisms. First, the removal of precancerous adenomatous polyps at the time of the index examination and the detection of CRC at an early stage reduce CRC incidence and/or mortality. Secondly, stratification based on the endoscopic findings allows patients at greater risk to benefit from endoscopic surveillance. Patients with adenomatous polyps are at greater risk of future development of advanced neoplasia, adenomas greater than 10 millimeters in size, or with unfavorable histology or cancer. This may be because serious lesions were missed or are not radically removed at the initial examination, or because an inherent imbalance of cell proliferation in an individual leads to accelerated carcinogenesis in apparently normal mucosa. With several European countries initiating population-based screening programs, the burden of surveillance can be expected to increase in the near future. Although colonoscopy is generally regarded as a safe procedure, a risk of major complications remains. In patients at increased risk of developing cancer, the balance of benefit and risk is generally regarded as favorable. However, the risks, albeit small, may become relevant if the gain associated with surveillance colonoscopies is substantially reduced. For the best balance between the benefits and drawbacks of post-polypectomy surveillance, it should only be offered to patients with a substantial residual risk of CRC. Epidemiological and clinical studies have shown that it is possible to stratify the risk of CRC and to identify a small subgroup of patients with a greater incidence of CRC that persists after baseline polypectomy. The European Society of Gastrointestinal Endoscopy commissions the development of evidence-based and consensus-based guideline to provide caregivers with a comprehensive review of risk stratification following removal of precancerous neoplastic lesions and with practical recommendations for scheduling endoscopic surveillance. This guideline does not address surveillance after endoscopic or surgical resection of a malignant polyp or surveillance in patients affected by hereditary colorectal syndromes. This guideline is an official statement of the European Society of Gastrointestinal Endoscopy. The grading of recommendations, assessment, development and evaluation system was adopted to define the strength of recommendations and the quality of evidence. In their paper entitled Post-polypectomy colonoscopy surveillance, European Society of Gastrointestinal Endoscopy Guideline, Hassan et al. Discussed the ESGE guideline in endoscopy. The following are the main recommendations. The following recommendations for post-polypectomy endoscopic surveillance should be applied only after a high-quality baseline colonoscopy with complete removal of all detected neoplastic lesions. 1. In the low-risk group, patients with 1 to 2 tubular adenomas less than 10 millimeters in size with low-grade dysplasia, the ESGE recommends participation in existing national screening programs 10 years after the index colonoscopy. If no screening program is available, repetition of colonoscopy 10 years after the index colonoscopy is recommended. Strong recommendation, moderate quality evidence. 2. In the high-risk group, patients with adenomas with villus histology or high-grade dysplasia or 10 millimeters in size or 3 adenomas, the ESGE recommends surveillance colonoscopy 3 years after the index colonoscopy. Strong recommendation, moderate quality evidence. Patients with 10 or more adenomas should be referred for genetic counseling. Strong recommendation, moderate quality evidence. 3. In the high-risk group, if no high-risk adenomas are detected at the first surveillance examination, the ESGE suggests a 5-year interval before a second surveillance colonoscopy. Weak recommendation, low quality evidence. If high-risk adenomas are detected at first or subsequent surveillance examinations, a 3-year repetition of surveillance colonoscopy is recommended. Strong recommendation, low quality evidence. 4. The ESGE recommends that patients with serrated polyps less than 10 millimeters in size with no dysplasia should be classified as low risk. Weak recommendation, low quality evidence. The ESGE suggests that patients with large serrated polyps, 10 millimeters in size, or those with dysplasia should be classified as high risk. Weak recommendation, low quality evidence. 5. The ESGE recommends that the endoscopist is responsible for providing a written recommendation for the post-polypectomy surveillance schedule. Strong recommendation, low quality evidence.